Thank you. So we are start kicking off our first general body meeting of the year. January was a whirlwind, obviously with COVID and everything going on. Couldn't get traction until this March, but I'm happy everybody was able to join today. I'm gonna start off every meeting with our mission. Our mission is to increase the number of culturally responsible Black engineers who excel academically, succeed professionally, and positively impact the community. Our mission is clear. Our agenda today, we're talking through a couple business items. I want to share our calendar of events as we're gaining traction for the year. We've got a few new executive board members I want to introduce to you all so you know their faces and names. We'll go through the rest of the calendar for the year. We've had to postpone a few items, so want to make sure we have good participation on those things that we are planning to do. And then I want to throw just a reminder out about NSBE 47 and some other professional development events coming up. Then we'll introduce our speaker and we'll open it up for a talk from Dr. Ward. We thank her for joining, and hopefully we can make it interactive since we have a smaller crowd. And as I mentioned before, we'll be doing some raffling in between here and there for some Grubhub gift cards for people that have taken the time to join us. So kicking it off to our executive board, we have two new members I want to introduce to you. Our social media chair, Mr. Laditra Dee Lee, and Carrie Washington, who's taking the role of pre-college initiative committee. And, you know, we're hoping that she gets enough comfort to make it official as a lead, but she's been involved up to this point. So I want to make sure everybody got to know both of them. Laditra is a computer science major from Jackson State University. I think somebody else was representing. I can't remember who, but
he doesn't have his camera on.
Hey, her husband went to Jackson State also.
Oh, that's true. Yeah, my bad, man. Yeah, that's true.
Yeah.
Y'all met there. Yeah, met there. So we appreciate Dee Dee coming on. She's born and raised Memphis, Tennessee, Delta Sigma Theta. You can read the details there, but she's been involved in a number of organizations in the community and has most recently been recognized as an outstanding leader for at Charles Schwab. And we appreciate her coming on and helping us on our social media presence. Dee Dee, smile for the camera. Say hello, please.
Hello. Thank you.
And Kay Wash, she doesn't have a camera on, but I'm going to put her on the spot. She's up next. She is, again, getting involved with our pre-college initiative. Our former chair, Shaq Tinley, moved out of town for career opportunities. So him doing a great job. He set up some of our key initiatives in Fresh Start and Engineering Day, and we hope to continue that and add more over the upcoming term. So Carrie is currently at Microsoft as a director, and she's working with the automotive, wireless, telecommunications, and technology industry for over 20 years. Her current role is with the Modern Work Advanced Communications Technology Sales, and she's in charge of US and Canada. She's also involved in numerous STEM-related and youth-related activities in the community, and we're looking forward to her sharing and bringing her energy to the board and to the local chapter initiatives that we have going on. Say hi, Carrie, if you're not going to turn your camera on.
Hello. Hi, everybody. Nice to see everyone virtually, and I'm excited about Dr. Tina Ward, and I'm excited to join NSBE.
All right. And we thank both of you all for joining our executive board. You can go online to our website if you want to get bios on the rest of the board members as well. I'm going to ask that we take a quick moment to do a quick raffle. So if you are Choose at your will. All right, so I am going to go through just a couple of things, just to update on our calendar of events. So typically we would have our engineering day that coincides with engineering week, which is in February and was in February. We had a couple of events that we were planning. Of course, the Texas freeze dropped all of that out of possibility, the realm of possibility. And we just decided to push things out a month rather than not do it. Obviously with March kind of being on the upcoming, we didn't have time to publicize and kind of pivot. So we're looking at April for our engineering day. This is the day where we take our students, typically when we can, non-COVID days, to actual sites for different companies and for them to see firsthand what an engineer does in their respective environment. So we do different STEM companies. Years past, we've gone to San Antonio even to visit the Toyota motor manufacturing plant. Last year we did Visa, Intel, and the Clinical Education Center down next to Seton. So if you are at a company that you think would be a good place for us to do really like a day in the life of experience, with us being virtual, we can expand that. So even if your headquarters is somewhere else, or maybe you have a contact with another company that might be able to do something like that, give us a shout. You can send an email to pci@nsbeap.org, or just send it to me, the president, at nsbeap.org, and we'll follow up with you. One of the things we did during Fresh Start that will likely integrate into the experience is the remote distance learning with the Houston NASA Space Center. They have a number of workshops where they walk the students from traveling into space and having the actual suit, space suit, walking through that, or the space shuttle itself. So they have some engaging activities that we'll make a part of that. So that's coming up in April, more than likely the third week, as the first week, as you'll see, is National Convention. For March, we have obviously the general body meeting. And then on the 25th, Thursday, the 25th, you should have gotten an email about this if you're on our listserv. 6:30 to 8, we're having a professionals roundtable with the University of Texas Austin NSBE chapter. This is something we do annually with them, just to engage and give kind of a more one-on-one experience with Austin professionals and the college students that are pursuing engineering degrees, to give them kind of your words of wisdom and insight, answer questions, just kind of a more informal conversations around what it's like to work as a Black professional in tech. So we're doing this virtual as well, and we need about 10 professionals to be a part of the breakout rooms that we'll do over Zoom to meet with these smaller groups of engineering students. So that's on March 25th. There is an Eventbrite link that I can post momentarily in the chat for you to be able to register for that if you're interested. Okay. And cool. Thank you, Aaron. And then May, we have our last general body meetings. Just for those that aren't familiar with our usual cadence, we do our general body meetings, which are the meetings like this, where we're meeting on a different topic every other month. And then that other month, we're doing some type of networking, or just more social event if we can. And obviously with COVID, we scaled that back a little bit, but we expect to start being able to do that in the fall. So June and July, we have a break, depending on where things stand with, vaccine, and Dr. Ward could probably give us her recommendation. We would typically have an intern mixer sometime in the summer, where we bring the people interning at different sites in Austin, tech companies like Dell, Microsoft, Facebook, Google, and allow them to just interact with one another while here, and we kind of give them a welcome as professionals. We'll play that one by ear, but hopefully we can do something if they are in fact traveling to companies here. Last year they weren't even doing that type of thing, so it didn't make sense to do it. But any questions on our calendar? The last thing I wanted to mention was the national convention, which will also be virtual this year. It is scheduled for April 5th through the 9th. I believe the early registration or the current rate will go up at the end of March. So if you're interested or have a company interest in attending, you can sign up for that going to convention.nsbe.org. I did want to just put a plug for the professional development conference that is planned for August. This is the conference that is solely for the NSBE professional chapters. That's pdc.nsbe.org. That will actually be in Dallas, so up the street. If you're so inclined to attend, please do so.
That's in person plan for, right? E?
That's correct. Yeah, it's at the Addison Hotel is the current plan right now.
I was really hoping that the first time that they open it back up in person, we can go back to Miami or San Diego or something, you know.
Right. Yeah, San Diego was the last one and that was the one I attended, and then Miami got canceled. So, yeah.
We need to run that back.
I would hope that we still have a deposit or something that we can redeem, right? So I'm thinking of putting it on the back end. They're usually 2 or 3 years ahead in terms of their site, so I'm thinking they'll run it back. Welcome back and congratulations. I'm going to move towards our guest speaker introduction. Again, we thank Dr. Ward for joining us today. She's been a part of our NSBE extended community for some time now. I mean, we're just hearing that she was or has been married to Brother Ward for, is it 31, you said?
Yep.
31 years. Awesome. So Dr. Ward is the founder and president of Austin Black Physicians Association, ABPA. The mission of the organization is to improve health disparities within our community and to inspire and nurture the next generation of Black doctors. In 2005, Dr. Ward was the co-founder of the Central Texas Association of Black Physicians, which provided networking and support opportunities for local physicians and mentorship for aspiring doctors. Dr. Ward received a BS in nursing from San Diego State University and her doctorate in medicine from the University of Illinois at Chicago. She completed her internship and residency training in Austin at the former Breckenridge Hospital, which is now Dell Seton Medical Center. She has been serving the Austin community as a family practice physician for 25 years. Dr. Ward saw patients in her own practice, private practice for over 8 years. And later, she worked as a medical consultant for the state of Texas's Health and Human Services Division, specializing in disability determination. She has spent her career dedicated to improving the quality of healthcare provided to the underserved population. Dr. Ward focuses on patient education, which is a critical factor in decreasing the health disparities that exist in our community. She is passionate about inspiring and motivating young Black students interested in becoming a physician. Dr. Ward resides in Austin, Texas with her husband, Ed Ward, who is a senior executive at Dell Technologies and a lifetime member of NSBE. Dr. Ward, thank you for taking the time to join us today. Welcome to take it. So, Dr. Ward, I'm gonna let you open up and then we'll take questions.
Will do, Bill, will do. I wish I had known that I didn't have to do this long lecture. I probably would have been at the beach for a little longer today in San Diego. So I am in San Diego currently at this time. But before we get started, I wanted us to take a moment to reflect on the past year because we are approximately a year out from when we first realized that we were going to have to live a life with a new reality. This past year, we had countries across the world entering into lockdown with travel restrictions, churches, closures of schools, non-essential businesses, sporting events, etc. And with the death of over 2 million people worldwide at this point, and over 525,000 deaths in the US alone, 29 million cases of confirmed COVID-19 in the US, we are still adapting to this new reality as we are wearing masks, social distancing, and washing our hands frequently to prevent the spread of COVID-19. Well, I think there's finally a light at the end of the tunnel, and that hope begins with vaccination. And as a physician, I took an oath to do no harm. I advocate for my patients, providing the best possible care regardless of race, ethnicity, or other discriminatory factors. Unfortunately, that's not always the case in our community. So my goal today is to provide you with some of the scientific evidence and facts to enable you to make informed decisions about your health. I would like to start. You can jump in anytime if you have any questions, but I do want to talk a little bit about how vaccines work. Sometimes we talk about vaccines, but we don't give people the information so they can understand how the immune system even functions. We need to start out by talking about white blood cells are there to fight infection. We have macrophages that swallow up germs and dead cells and leave behind parts of the invading germs. And that's what you've heard called antigens. And our body has B lymphocytes that produce antibodies to attack these pieces of virus that are left behind, called antigens. T lymphocytes are also called memory cells. They attack the cells in the body that have already been infected. So I'd like to start out by talking about the mRNA vaccines. You know them as Pfizer and Moderna. mRNA vaccines, there's a lot of myths out there and misinformation. So I would like to address some of them. The mRNA vaccines do not contain live viruses. Messenger RNA provides instructions for your body to make more copies of the spike protein. There's a specific protein that is on the body of the surface of the SARS-CoV-2 virus. And the mRNA vaccines are literally having our body, giving them the information so they can make this tiny protein that's part of the virus. So when people say, can I get COVID-19 from the vaccine? That's not possible because the messenger RNA does not contain any live viruses. And another myth is that the vaccine can actually change your DNA, but the mRNA although it is genetic material, it never enters the cell or the nucleus of the cell. And that is where your unique genetic material called DNA is located. So the myth that the vaccine can alter your DNA is obviously very false. So obviously your immune system recognizes this spike protein as foreign, and the B lymphocytes produce these antibodies to attack the protein and neutralize it. And the T lymphocytes, also known as memory cells, jump into action the next time you encounter the virus. So I know that's a lot of information about the immune system, but if you understand that, you get a better understanding of the different types of vaccines that we have. The Johnson & Johnson Janssen vaccine is a DNA vaccine, unlike the mRNA vaccines. They both deliver the exact same information, which is the genetic code for our bodies to manufacture the spike protein that ends up protecting us. To manufacture the spike protein for our bodies. And the protection occurs about 2 weeks after you're vaccinated. The nice thing about J&J is you only need one dose. It has less stringent cold storage requirements. It's about 68 to 72% effective at preventing lab-confirmed COVID-19 illness. And I say that because sometimes people say, well, does that mean that it's going to prevent me from getting COVID-19 in terms of symptomatic versus asymptomatic infection? That is not something we're aware of at this point. We do believe that it does prevent the asymptomatic carrier state. There's early evidence that J&J does do that, but we're still looking at the data at this point. Obviously, everybody's aware that we've had over 92 million doses of vaccines given at this point, and that has allowed us to look at a lot of the side effects that have occurred. So when you hear all about the vaccine hesitancy and people deciding they really are uncomfortable with the side effects, we have seen from all the trials that there is actually no serious consequences and side effects that result in serious disease or hospitalization or death. We do have a small percentage of people that have anaphylactic reactions. That is severe allergic reaction that's treated with epinephrine. The other things I wanted to mention has to do with the concern that I get regarding the speed in which the vaccines were generated, being that they were generated in months rather than in years, which was typical a long time ago. But I do want to say that the emergency use authorization by the FDA still followed the strict guidelines without compromising safety or efficacy. In other words, the time that it took to develop the vaccine simply cut out the bureaucracy, the paperwork, the timing that normally we take exorbitant amounts of time to prove. So I think that it's a good thing, and we do know that the safety and the efficacy was not compromised. So I feel really comfortable about that. Scientists were already working on the technology for mRNA vaccines ever since 2003 with the SARS outbreak. So basically, all the pandemic resources worldwide were poured into the development of these vaccines. The phase 1, 2, and 3 clinical trials that were carried out, we normally take a longer period of time in phase 3 clinical trials in which we look at the side effects. That was something we didn't take as long as we normally do. We had about 2 months looking at the side effects. Most of you are aware of some of the side effects. If any of you have had your vaccine, you know that a sore arm occurred in the majority of people. There's some people who didn't get a sore arm. Redness at the vaccination site, swelling at the site, the injection site. It usually lasts about 1 to 2 days. We also have systemic side effects, fever, chills, headache, fatigue, some muscle aches and joint pains that occur. And they're very mild, usually 1 or 2 days. So at this point, I try to tell people the side effects that are obviously more common after the second dose are definitely a very small price to pay for saving your life as well as the life of your family and friends and society. So those of you who are hesitant to get the vaccine due to the possible side effects, I would really implore you and tell you over and over, these are very mild side effects. And at this point, I think that our focus needs to be that the benefits outweigh the risk significantly. I'd like to open it up for questions before I kind of just jump into all the most commonly frequently asked questions in terms of talking about when you should get the vaccine, which one's better than the other. So I think I'll open it up to questions rather than lecturing any longer, because we have such a small group. I think I'd like to hear what you need to know.
Yeah, we did have one question that was posted in the chat. It said, within the last week, I'm hearing that if you were vaccinated, the probability of you being able to spread the virus is very low. Is this latest information from trials / studies that have been recently published, or is this, anecdotal information that hasn't really made its way through the rigor of trials?
So the trials that we have only looked at people for about 2 months, but they go all the way up until 2 years. So they've started looking at the data to see if they have developed these side effects. And if so, the endpoint, which is what she's asking, is, are you an asymptomatic carrier? The trials themselves literally were looking at whether or not you had clinical symptoms of COVID-19. COVID-19. So they really weren't looking at whether or not you actually produce antibodies and could have COVID-19, but no symptoms. But now that we have more data and we've been looking at the scientific evidence based on the fact that we vaccinated this many people and the fact that they haven't been carrying the virus despite, not having symptoms. So I think we know at this point that that asymptomatic carrier state is present, probably 80%, 90% certainty. But until the studies have been done, we truly can't definitively say no.
And I think there's another question that is surrounded, and you may be alluding to it in your about, we have different companies that have created different or created vaccines with different approaches. You mentioned the mRNA approach versus the DNA approach. How does one decide which is right for them? Is there a physiology that we should pay attention to? Is there a more
Scientific
greater risk
method?
for certain people with ailments? Yeah, like is
Yeah.
there, we're engineers, so we want to know, like, all right,
Of course you do.
what's the control? What are the variables?
I wouldn't expect any less from you than I would from my husband asking the exact same question. So in reality, the CDC's answer to you is going to be all the vaccines are truly equal. What I would tell you is that it's very hard to compare the efficacy of these vaccines because they were studied at different time periods, different populations, different geographical locations, and different circulating strains. As you're aware, the J&J vaccine was tested on some of the strains, the South African variants, the UK variants, as well as the Brazilian. And so sometimes what we do is we get into the weeds. That's what I call it. Which vaccine should I get? I have to be honest, they are all pretty equal. Initially, we thought the J&J, when you look at the clinical studies, it'll say it's only 68 to 72% effective in preventing COVID-19 symptoms. Well, that efficacy was measured differently from the 94 to 95% numbers that we quote with Pfizer and Moderna. So when we really look at the data, they're all pretty equal. So any vaccine that you should get, you should get. Initially, we were even telling people, well, the fact that when you get Pfizer or Moderna, about 4 weeks into it, you're really 70, 80% covered anyways. So do you really need the second dose? The answer is yes. You need the second dose to get to that 94 to 95% efficacy. Whereas the J&J was only studied with one dose. So you got to that efficacy, they quote 72%, but you got to that efficacy 2 weeks after a single dose. So it's very similar to the other one. We just don't have the numbers to compare them.
So you wouldn't say, from your medical professional, one is best versus
Definitely not.
the other.
And most of my colleagues are saying the same thing. You're going to see a lot of information out there that'll say, oh, I get less side effects with Pfizer, or I get less side effects with Moderna. All of that just has to do with reporting information right now. As most of you are aware, you have VSafe, different ways of reporting what's going on right now and who has what symptoms. And the reality is it comes down to reporting. The research shows the side effect profile is pretty much the same for all of them. The only difference is with J&J, you're not going to get the side effects more than one time. That's a motivating factor for many people.
And so what do you say to people who ask about how long the vaccine will be effective? And obviously knowing that we've only started to give the vaccine in the past
Correct.
year, right? So there's is there already research showing the effectiveness of waning for those ones that were in trials?
No, right now what we show is the vaccine is effective for at least 90 days. Anything after that, we're not really sure. We know that there are people who had the vaccine and it's still effective at this point, but we can't tell anybody that you're not going to have a booster shot, when the fall comes around. Because this could be very similar to the influenza vaccine, in which you end up getting a booster shot every year in the wintertime. So we don't have any data that says it's effective for 6 months versus 7 months. What we do know is it's as effective as having the disease. Actually, they actually showed it's more effective than if you had the natural course of the disease, that the effectiveness lasts for 90 days where you're not going to get, the illness again. Supposedly, it's a very rare occasion that people do get it within that 90 days, which is why we tell people, if you've had COVID-19, please wait 90 days to get the vaccine, just to give other people an opportunity to get the vaccine more than anything else. It's not that a month after it, you can't turn around and get the vaccine, to increase your effectiveness of preventing COVID-19 disease. So we only know 90 days in answer to your question.
So let's hold into what you just mentioned about people who've had COVID before,
Mhm.
and there, certain people believe that, oh, I've had it before, I got the antibodies, I don't need to get a vaccine. Is there any recommendation there? I know you just
There
mentioned
is.
waiting if you've had it.
There is,
but
because what we do know is that just because you've had COVID-19 before doesn't mean that you can't get it again. We know there are numerous people who have got it again, but they don't usually get it within that initial 90-day period. We don't know how much antibody production you had with your initial infection. So you need to protect yourself as well as others by getting the vaccine. That is the recommendation for that reason. And there were people who had COVID-19 in the actual vaccine trials as well.
A quick question, and I think this may be something that even Ed can chime in on as well. I hate to bring it up because it's so ridiculous. With certain communities, there's a thought that the government is trying to take over us with inserting nanotechnology into our bodies through the Moderna, Pfizer, and Johnson & Johnson shot. Can both of y'all give both a medical and a technological response to that?
Ed, would you like to address the technological response to your engineering cohort?
Sure, but I think maybe you ought to talk about the lipids that are used to deliver the genetic instructions first, and then I can talk about the technology piece of it.
It has more to do with how fragile the vaccine is. And they have these lipid nanoparticles that it's wrapped in order to deliver the vaccine. So the fragility varies depending on whether you have J&J, which has a DNA vaccine, and that means it's not as fragile as the mRNA vaccines. So it doesn't have to follow the same cold chain. But in reality, the possibility of inserting anything that could have an impact on on killing people, on doing anything to their DNA, it's just not possible. So it's kind of like when people are telling you that the whole thing is a hoax, but yet we've had over 500,000 people die. There's a lot of conspiracy theories out there that make no logical sense. I'm a scientist, so we follow scientific data and evidence. So all of the political and ideologies out there are just that. They are not scientific data. So we can barely address those things when we understand what the vaccine does, and knowing that we're not putting anything that has any effect at all on your DNA or anything else that could impact that. Ed?
Sure. So look, the word nanoparticle, people are probably looking at it in terms of, is this nanotechnology, and are they then using it to insert data and things like that? Nanotechnology is just a way of talking about the particles that are at a certain size. and they have to be a certain size. And the reason they use the nanoparticles is so that the lipid nanoparticles specifically is because that's what can efficiently get the information to the cells and the way that your cells interact with things. Lipids are like fats that I'm getting out of my
They are.
here. But basically, it's something that your body is familiar with, but they can kind of, using the nanotechnology, they can architect it so that it efficiently delivers the information to your cell. It's not like a solid state silicons delivering bits and then sending, electrically conductive messages or things like that. But it is in the family of nanotechnology. But just like you can have different cars, and you can have cars that are built, or automobiles that are built for, Hummers to run on mountain roads, or Ferraris to run on other things. They're all cars, but they're built for many different uses and different things. That's kind of the analogy I would use from the technology side of things. So yes, it's nanotechnology, but it's not like they're putting nanobots in your body that are going to then like take over and do things like that. It's that that type of technology allows them to then architect it in a way that it can interact with your body, so it can deliver the genetic information, so that, as Tina said, your cells can produce the spike protein, which is then what's needed so that your body can go and produce the antibodies to that. So when the real spike protein shows up with the COVID-19 virus, you've already got the antibodies that you can go take it out before it can do something to you. Does that help, Greg?
That does. And specifically, I'm glad you mentioned specifically the nanobots, because one of and I consider her like if I was to have a second mother, she would have been my second mother, who's believing that now.
Yeah, well, there's fear and
uncertainty. I'm my best, and she's denying the vaccine, and it's the most ridiculous thing. And I just
look, there's fear and uncertainty and doubt, and people fear what they don't understand, right? And so nanotechnology, not a lot of people understand it. They just think, oh, nanobots, and I heard the nano that worked with that, and then that's going to go control me, et cetera. That's not what's going on here, but it's the same. It's a technology base of being able to deal with things at the nano level, and then being able to architect the lipids so that they can efficiently interact with your cells, because that's what your cells interact with, to transfer the information from that carrier that's carrying the mRNA information to then get into the cell and then cause it to produce this protein that will cause you to produce the antibodies, as Tina said. So it's the same base technology, just like a Hummer shares the same base technology of a combustion engine with a car or other things, but it isn't the same thing as a Ferrari, right?
And I think the important thing too is that these are not robots that are really, really tiny.
Right. That's what I'm going to say.
That's just not
robots are different things, right?
They use the term nanobot just because it sounds cool, but it's not quite the same thing.
Well, it's just miniaturization. It's the miniaturization of it from the nano. A nano is basically a 10 to the minus 9 meters. We all know what that is, or engineers do, right? It's just a matter of the scale at which you're talking about it. That's why they use the word nano, as opposed to, oh, that's a nano robot now. Well, that's not what it is.
And just going a little further into it, just because I did work in the nanotechnology division at Ames Research Center.
There you go.
The physics at that level are totally different than physics at the scale that we are used to seeing robots operating. So just imagine working in the nanoscale where you're having to account for electrons force versus a cell's force in terms of like magnetic forces and interacting particles. So it's just not a relevant application of that particular technology to say somebody could be controlled by the mind. What would likely happen is that you probably, whatever you get shot with would probably get eaten by white cells in a matter of minutes.
Exactly.
And dissolve in your skin. I mean, in your bloodstream, and that'd be it. So it's just not a thing. There's a few more questions.
Okay.
That I thought was a good question. With the idea of having to have a booster shot, does the type of vaccine you got initially, would that play into what type of booster you have to get? So let's say you had, the Moderna, which was the mRNA, would you have to get another booster with that particular, style of vaccine, or does how does the booster work?
So right now, the way we're looking at it is if you have Moderna, you have to stay with Moderna. If you have Pfizer, you stay with Pfizer. And the same with J&J. Well, the difference is, let's say you had a horrible allergic reaction to the mRNA component. Then that's somebody who we can consider using J&J with, the other vaccine, because that is a different type of vaccine. But in terms of the booster, think of it as, you know how we keep coming out with different strains? You've heard about the UK variant, the South African variant. As we get further and further into this process, there will be more variants. So we will have to go in and adjust the spike protein. So the boosters will be geared towards that. It makes it easy to adjust based on the fact that it's an mRNA vaccine and you can just adjust a little bit at a time. So that's what the boosters will be. So yes, it does matter what you got in terms of mRNA versus DNA, because you understand that J&J was tested later. So it's effective against some other strains that we're not sure are effective with the mRNA technology.
I guess one more, a few other questions, like as it relates to, can you walk through the reason why BMI is so high on the list, and that quite a few people who may not have the known ones, but because their BMI is could automatically qualify?
Well, what happens with obesity, and they actually did a study recently that looked at comorbid diseases and what effect that has in terms of the consequences and the seriousness of your illness. Body mass index and obesity causes a lot more inflammation in the body. And it's well known that this virus causes inflammation that affects all your systems in your body, inflammation in the heart, the lungs, your entire nervous system. So when you are morbidly obese, so your BMI over 30 has some impact, about 113% more likely to have serious disease with a BMI over 30. Well, when you get a BMI over 40 with morbid obesity, that percentage changes dramatically. The number of people who end up on ventilators, who end up with other serious consequences, go up. So that's why the BMI and obesity is an independent risk factor when we talk about comorbid diseases, why it's as significant as having coronary artery disease and some of the other comorbidities that we talk about, chronic kidney disease, lung disease, COPD, asthma, other diseases like that. So when people look at Blacks in general, they will say, well, Blacks have more obesity in general than whites. So they're more obese, so they're higher risk. That is one of the reasons. It has to do with the effect that it's disproportionately affecting us, has to do with obesity as well as hypertension, diabetes, other comorbid diseases that are more prevalent in our population. So I would venture to say that many of us consider, let's see how I can tactfully say this, us as healthy with higher BMIs rather than obese. And I would advise people, there is a reason that we consider obesity a national health crisis, because it predisposes you to numerous things. It predisposes you to heart disease, hypertension, diabetes. So obviously obesity is something that we do need to address.
And just to let everybody know, I'm obese. Just want to let you know I'm a fat boy right here. And that qualified me to get the shot. So she don't want to say this, but I say it. And I think it's important. And I'm 5'11", I'm 240. The 240 was before. That was before COVID, so I can't blame COVID. So I was fat boy before then. So the reason I say this, I'm 5'11", 240. That's the two factors that go into this. If you around that area, it might be important for you to consider whether or not you fit my category and qualify for 1B as well, to go get the vaccine right now. I'm just want to throw it out there. I'm the child I vaccine 2 weeks ago. You don't qualify because you stick.
Yeah, I'm behind.
We do appreciate that, Greg, because it is something that people don't like to admit. And as physicians, I have to admit that when people come in the office and you bring up weight, they shy away from it. And, you know, it's a subject that we have to address and recognize. So thank you, Greg.
I'll be the poster child. The second question that I wanted to ask is relates to like, what's the counter? Because we know that, well, if I'm understanding correct, right now, let's assume no vaccines in place. But my aunt said that when she got plasma, she was in the hospital at that point 4 days. It seemed like as soon as she got plasma, the 5th day she was feeling substantially better. It worked for her, but unfortunately we lost her mom to COVID, and the plasma did not work. So
Yeah.
specifically, and when it was good, can you break it down to why is plasma? Not to mention you start to hear more people asking, even on the radio. I think I heard, you know, can you all start giving plasma? Why would that be significant?
Well, because we've looked at numerous treatments for COVID, and using convalescent plasma as well as monoclonal antibodies early in the disease process has decreased the seriousness and the number of hospitalizations. So those are treatment options that initially were just reserved for people who had physicians who, how shall I say this very tactfully, who were more assertive and aggressive at treating those populations. And it often wasn't offered to us. When I would call some of my relatives and say, did they offer you any convalescent plasma or monoclonal antibodies? And they'd say, no, I've never heard of it. The doctor never even mentioned it. Well, now it's becoming much more known. So you're just hearing about it now, but we've known about it and been utilizing it for a while. You know, it's one of our treatment options. That's what's become a lot more impressive is our treatment with COVID-19 disease. Sometimes, you know, we don't understand who's going to die from it. There are people who don't have any comorbidities and they actually die from COVID, and we can't explain it. We don't know why they weren't high risk. Why did they die? So when people tell me, why should I get the vaccine? Sometimes I look at them and I say, I don't know how your body's going to react. The same way your aunt responded day 4. Well, my uncle didn't respond at all. Well, everybody, their body responds differently. So we've been using those as treatment modalities. If you've had convalescent plasma or monoclonal antibodies as treatment for your COVID, you cannot get the vaccine for 90 days. It's really important that you wait that 90-day period and let them know. So there's lots of things and reasons why we tell people you have to wait. And your body literally is producing all these in that process. So you don't want a vaccine thrown in at that time where it's not going to have an impact.
So let me ask you about tracking of the vaccine. What have you seen in terms of when people get the vaccine? How well are they being documented? And, you know, we've heard of the cases where people have scheduled appointments to get the vaccine. They didn't show up and other people were able to get theirs. Are those being tracked? And, or, you know, how do you see us moving forward with being able to know what the true population
Well,
is?
I think right now what's come out is the AMA has decided that it's really crucial that we actually track race and ethnicity. And there's a reason for it, because we are not being vaccinated at the same rates as other people are. And one of the reasons that occurred is people did have appointments. And when they had appointments and didn't show, people were preferentially given the option to come get the vaccine when they were not even high risk. So now we're doing a much better job, which is why the government, you know, rolled out hubs and started making all these new changes so that we could really track who we're vaccinating. And doctors actually can get prosecuted now for vaccinating people who are low risk and outside of that 1A, 1B and high risk categories, frontline workers, et cetera. And before, people who had money were vaccinated very early on. And their communities were saying, hey, I got it here. I can drive 2 hours and go get it. And now a lot of us who need it, people who are over 75, over 65, can't get the vaccine right now. But that's going to change. I think we're making some headway right now. And our goal is that by the end of April, end of May, we should be vaccinating the entire public. And I think by August, September, our goal is that everybody should be vaccinated. If Joe Biden, our current president's recommendations and his aggressiveness stands, and we also go get the vaccine when it's our turn. You know,
Hey, Dr.
some
Ward.
people are still resistant to getting the vaccine. And it's very sad because what I have to tell people is you may not get COVID-19. You may be an asymptomatic carrier. You may give it to your mom. You may give it to your grandmother. You may give it to the person next to you. You may give it to a household member who is immunocompromised. And when they die, or if they die, you have to live with that guilt. And there are numerous people who are living with that guilt right now. It is not something that you want to deal with. It is when people say, well, am I my brother's keeper? Why do I have to be responsible for other people? Why can't I just be responsible for me? You don't live in a little bubble. We are all responsible for each other. We have an obligation to make sure that we're protecting other people as well as ourselves. So not wearing a mask doesn't really make sense when you know that you could get somebody else sick.
Hey, Dr. Ward. Yeah, so I appreciate all that. I agree with all that good stuff. I guess I was more thinking about is there like a public database that either people or employers or anyone can access that doesn't matter if you got your vaccine from HEB or Walgreens or whoever, that is kind of government controlled and shows like, here's who has it and here's what vaccine they got. I'm thinking about like a massive Google Sheets, you know.
I can tell you, Aaron, that's not public.
Well, okay, so let's take the public out of it. Like, even if it was just private, like I'm imagining, like when the whole vaccine rollout first happened, I was just wondering, like, if it was going to be this scarlet letter situation where, like, hey, I got mine. This is my official card. I'm licensed to go to the movie theater or something like that. You know, and I guess, but more so, like in practical terms, again, an employer that's like, hey, if you are vaccinated, you can do certain tasks without, you know, certain PPE or something like that, or just even like, hey, I forgot which vaccine I got, or I had to go out of town for, 10 weeks and now I'm back, like I need a second dose, like all the logistical challenges. I'm just wondering, like, type of centralized orders. Walgreens have their own, CVS has their own.
No, Aaron, it is centralized in that sense. Okay. So what happens is we have a vaccine database, and everybody has to report into that database. That way, we always know what vaccine you had. If you had Moderna, you can't come back and tell somebody I had Pfizer. You have a card, but we also have a lookup that can tell us what you had. So it's being tracked, which is why I think sometimes we get the bottlenecking that you see, because some people, are delaying. You have to put that information in the database because we have to have it. That's why the process is so complicated. Unfortunately, one of the problems we have had is you don't have race and ethnicity in there. And that is what we are calling for right now, because we see the discrimination that has occurred. And we really need that to change.
Is this Tina, is this information that's in the database, is that any different than information that's in databases about when you go get a prescription at Walgreens or prescription at CVS or anything like that?
Yes, it is. So the information that's in the database is a database that is by state. So every state has a certain database. Most of us use the same national database, but everybody has to enter the lot number, the vaccine, the person, all of that into the database. It's not that Walgreens put it in. You have CVS and you have Walgreens, and they all have their own system. Everybody has to enter this data into the VAERS database.
But is this a different database than, let's say I'm getting the flu vaccine on a normal cycle? Is that being reported?
Yes, because
the same?
that's not a mandatory reporting database.
Okay, gotcha.
This is a mandatory reporting database. So when you have MMR, certain vaccines, it's mandatory to report those vaccines now.
So would we eventually see in similar cases where, you know, you go to another country, you got to have yellow fever? Would we see a stamp now for COVID?
It actually may happen in claimants because every country has to decide what impact they want to let you coming into their country have.
Mhm.
And when Aaron mentioned one thing, I will address for you, Aaron. Employers are having to decide how they're going to handle this in terms of mandatory vaccination. It's a sticky topic. There's lawsuits that will be coming out regarding it when somebody tells you you have to be vaccinated against COVID. You know, but employers, private employers have the right to do this. Now, it gets a little sticky when you're talking about the public employers. So there are some people who have exceptions, medical exceptions to vaccination. But right now it's getting a little sticky. There's a lot of data out there. So we'll see what happens. As you're aware, things are changing. I have to admit to you, I have to read probably an hour every single day on the updates. And it's not fun because things are changing constantly. I can have this talk with you, and in 2 weeks, I'm telling you something else. You just saw the CDC came out, what, a day ago? Those of you who have been vaccinated, fully vaccinated means that you are 2 weeks out from your second dose. If you are with other people who are fully vaccinated, you can congregate in your small groups and take your mask off and not have to social distance in private small groups. But when you go in public, you need to put your mask on and social distance and do hand washing. So the thing is, CDC is we're trying to get back to a period of normalcy as soon as possible. So when you're vaccinated, it allows you to have that freedom to travel and know that you're 90% protected. And being protected means you can be comfortable that, like right now, once I got my vaccine, I'm out. I was due for my second dose today, but I'm in California for a funeral. But I will make sure I get it within that 42-day period because I want to be protected as soon as possible. I know I'm probably about 70%, possibly 80% protected, but I still have to put on my mask on the plane. I still have to put on my mask inside my friend's house right now. You know, she's in the car with me and we're traveling for an hour with mask on, even with the top down. So, you know, it's frustrating. I don't like it. I have COVID fatigue just like the rest of you. You know, it's exhausting. And when you see the mental health consequences that are happening right now with depression, anxiety, and everything else related to COVID, the loss of employment, the, you know, remote learning, we're going to be dealing with a mental health crisis as well as we transition into normalcy again.
But to your point, Dr. Ward, I think what you were saying earlier is that even after you have the vaccine, not sure if you can possibly be a carrier still, so would still have to kind of, I don't think masks are going anywhere from what I've read, even if you have the vaccine. Is that right?
No, so Aaron, it wasn't going anywhere, but what happened is, and I think what Dr. Fauci was trying to tell people is we hadn't done all the research on asymptomatic carriers safe, but they're gathering the data on it right now. We're further into it. Once you're 7-8 months out, you're starting to see, we hadn't done antibody testing. So now we can actually test how much antibody you're producing if you're really a carrier at that point. So as we're gathering the data, we're starting to let people take their mask off because we're seeing, oh, you really were not an asymptomatic carrier once you had the vaccine. We do think that's the case, but we really didn't want to jump to it. So when you think masks aren't going anywhere, once we get to herd immunity and we get literally that high percentage of people vaccinated, and also just understand when you get the vaccine, your chances of dying from it and being hospitalized are extremely low and rare, almost not going to happen. That is a relief that I cannot tell you I feel better about because I was in category 1B and now I don't worry about that.
So you actually touched on one of the last questions. We'll just take these two last questions and we'll close out since we're getting close to the hour. the question is, does everyone need to get the vaccine, or is there a percentage of the population that we get to herd immunity? So I think maybe defining herd immunity is probably the first thing to do as a part of that question. And it says, because there are plenty of people who just can't seem to be convinced to get the vaccine. So first, what is herd immunity really mean? And then, what does that translate into in terms of like how many people actually need to get the vaccine? And then the last question is, I'll throw the other question out just so we wrap up with questions, is with the dependency on a lot of this tracking being heavily relied on technology, and we're of the age where technology is everything, but there are a lot of older members of the society that don't have that technical know-how. Keisha was mentioning her grandmother. She's 90 and she's having a tough time scheduling online, because the minute you pull it up, it's loading and things aren't, right. So any recommendations on that to get our elderly vaccinated as well? So those two questions, and then we'll
really quick on the elderly, because that's a very easy question right off the bat. We have now come up with ways. Austin Public Health, for instance, a lot of the different hubs are reaching out to the elderly. They can do it via a phone call, but we also know that we're sending information out so we can literally call them and get them registered. So that is the new goal in the next couple of weeks. Austin Public Health will be doing that. Anybody that you know of, you will end up putting it on a website or calling people. So that is what we're trying to get to, because we can't expect older people to have the technology in their house and know how to use the computer. And all of you know that it was taking 2 hours sometimes to register on a website. You were being kicked off. There were all sorts of technological problems that occurred. So I think that we're finding a way to address the elderly right now in terms of not just the 1-800 numbers, but as we go on and they leave their message, we're reaching back out to them. It's not just the churches who we're partnering with that are doing that, but it's also Austin Public Health. So when you go on the APH website, there's going to be more information. If you're elderly, please click here or please call this number.
So hopefully that translates, because her grandmother's in Alabama. So hopefully that translates.
I think it's translating pretty much everywhere. So what we're dealing with in terms of herd immunity, there's not a specific number. We're encouraging everybody to get vaccinated for that reason. In general, it's over 80% of the population. And it varies everywhere because we need enough people to be vaccinated that your chances of coming down with the disease are low. And that gives us a chance to avoid all the variants that are popping up right now, literally.
Thank you, Dr. Ward. That was rapid fire.
Yeah, that was rapid fire.
You did exquisitely, and I appreciate your husband for chiming in on the nanotechnology.
Thank you, Ed.
We again,
by the way, the Ed Tina tag team.
Exactly, love it. We appreciate both of you for taking your time to share with the group. We have a president in our midst, and we just wanted to say congratulations to Ed, who was recently named. Is this like recent as of like yesterday, today, or
Monday? Yeah, yesterday.
Monday, yeah. President of Client Product Group at Dell, and to my knowledge, this is the first Black president at Dell. Am I right? Am I getting that?
Yeah,
that history fact right?
Congrats.
So congrats to you, Ed. We appreciate all the support that you have shown to the chapter over these years, and it's a well-deserved position. We know that you will represent hard and do well at it. So we wish you the best in this new role.
Thanks a lot, Clemus. Appreciate that. Thank you all.
Thank you, bro.
Thank you.